Hello, my name is Omar Yasin and I'm a first-year Cardiology Fellow at Mayo Clinic. We are here today at the ACC Scientific Sessions 2019 in New Orleans. We are joined here today by Dr. Tarakji, and today we're going to be discussing the WRAPIT trial. Thank you for being with us today.
Thank you, Omar.
So, tell us more about the WRAPIT trial.
So the WRAPIT trial is a trial that was designed to assess the effectiveness and safety of using the antibiotic envelope. The antibiotic envelope, Thyrox envelope, is made of absorbable mesh that releases two antibiotics in the pocket when you implant pacemakers and defibrillators. It wraps around the device itself, and it releases two antibiotics, rifampin and minocycline, in the pocket. And after 9 weeks, the envelope gets completely dissolved. So the trial was mainly to assess its effectiveness in reducing infection over a course of 1 year after the device procedure, and also to make sure that it's safe.
Tell us more about the patient population that will benefit most from this.
Sure, so I'll tell you about patient population that we tried to target. Our strategy was to include patients who are at increased risk for infection. And historically, we know that device changes and replacements or upgrades, they usually carry higher risk than initial device implantation. With one exception also, we included patients with initial or de novo CRT-D devices, cardiac resynchronization therapy defibrillator. So that's the cohort. The target was the world. It was a 7,000 patients global trial. It was a randomized controlled trial between one group got the envelope, that's the treatment group, and the other group did not get the envelope, and that was our control group.
So the results seem to be very encouraging for this trial. Can you tell us more details about the numbers?
Sure. So we followed all these patients up to 12 months, and the primary endpoint was major device infection at 12 months of follow-up. And the way we defined major infection, you need to fulfill the criteria for device infection. And by that we mean cellulitis with erosion, drainage, or deep pocket infection, or persistent bacteremia or endocarditis. Now, for the infection to qualify as major, it needs to lead to system removal, which, as you know, that's the standard of care for taking care of these patients, or pocket revision or extended suppressive antibiotic therapy, because, as you know, some patients are not candidates for lead extractions, or if the infection leads to death. So if the infection leads to one of the outcomes that I mentioned, that's a major infection. All the other infections, we classify them as minor. And what we found at the end of the trial, we found that the event rate in the envelope group was 0.7%. Versus 1.2% in the control arm. And that was statistically significant with relative risk reduction of 40% with using the envelope for major device infection over a course of 1 year. For the effectiveness, and that's for the effectiveness outcome, as far as the safety outcome, that was a secondary endpoint, we found that the envelope use did not increase the complication rate between the envelope group and the control group. So we found that the envelope was effective and also it was safe. The important point to mention also for us as a field in general, for electrophysiology, in addition to show the results of the effectiveness and safety of the envelope, is the fact that the infection rate in the control group was lower than we expected. It was 1.2%. And frankly speaking, this is something that, as electrophysiologists, we should all be proud about. And clearly, it's a testament for all the centers that they did the best they can. Because this is coming at a time when recently some data suggested increased risk of the risk of infection in general, and whether the rate of newly infected devices is becoming out of proportion of newly implanted devices. Now, we had the PADIT trial, the Canadian trial led by Dr. Andrew Cron in Canada, and that showed that the infection rate over 1 year, similar cohort to the ones that we studied, was about almost identical number, 1.2%, and that's now replicated with WRAPIT. So I think we do have a new standard that we should all reach to, especially among this cohort of patients with device replacements and upgrades or pocket revisions. So we're happy that the rate in general is low, and the fact that we can even get it lower, that's really remarkable.
Thank you very much. This is a very important topic because even though the rates, even in the trial, were on the lower side, about 1.2%, but having an infected device is devastating sometimes to the patients. It's a very big deal.
It is a big deal, and nobody understands how big of a deal it is more than the electrophysiologist. Nobody wants to do the lead extraction, and there are certain things that you really cannot measure. For example, somebody who's been a great responder for CRT device, and now you have to take that device out after a simple device change, and they deteriorate from heart failure. You might not be able to get back to that same branch. So it means a lot. In addition, we know from data that despite all the proper management, the mortality is still high 1-month mortality is about 4 to 5%. 1-year mortality is up to 15-18%. So we really need, this is one of the complications that we'd love to get as close to zero as possible.
Well, thank you very much for all the work of trying to make our interventions for patients a lot more safer. For more videos like this, please follow us on youtube.com/FITsontheGo. Thank you.